Good morning, everyone. This is David Buday. I'm here with my friend and partner, Tim Gutwald. Although when I say here, we're in two different locations. As we know, we're living in quite different times than typical. I'd like to start off with thanking everyone for joining us this morning. Following our webinar last Friday on rapidly evolving laws and related considerations in the employment arena, and after tracking the unfathomable ripple effects of COVID-19 on civic, commercial, and social life over the last weeks, Miller Johnson formed a cross-functional team to deliver timely and pragmatic resources to our clients and other community members. We believe we can best mitigate the fallout from this crisis by working together with our clients, with the government, community organizations, and other professionals. We practice and we live in a community that we believe prizes collaboration, intellect, loyalty, candor, and ingenuity. These will be our daily guiding principles as we navigate these uncharted waters and try to do our part in helping. Before we proceed to the substance of today's program, let us pause to consider the thousands of people across the world who have already been impacted by this pandemic, as well as the many thousands of lives, families, and jobs that will be impaired in the weeks and the months ahead. The pain, the anxiety, the fears, the uncertainty that too many of us feel. While we cannot stop what may come, we can adopt and must adopt a constructive mindset that recognizes our shared sensibilities to our co-workers, our employees, our business partners, our local economies, our neighbors, and the principles of law. And today, on this particular session, we focused on the healthcare industry. Folks who are in the healthcare industry in our communities are being put on the front line of this effort to combat COVID-19. On behalf of Miller Johnson and the community, I hope that you all know, and I hope you express it especially to those who are providing direct care, our thanks for what they are doing and what they're going to have to be being asked to do as this unfolds. Before we start out today, what we do every day when we do these webinars, which you do at 8 o'clock every morning, and I will be doing for the foreseeable future, we like to kind of level set some things that may have happened overnight. As we know, this continues to evolve quickly, and we just pick out a few items from the news and quickly go through those. Last night and early this morning, it was reported that in Michigan, we're now up to 117 reported cases. There were 37 reported cases on Wednesday. Unfortunately, we had our first death in the state of Michigan, a 50-year-old man in the Detroit area. Second, yesterday, the Senate passed and the President signed the Families First Coronavirus Response Act, and we'll talk about that a little today. Third, good news. China yesterday reported 0 new cases. A country of over 1 billion people that was under siege is now down to 0 new cases. And in Wuhan, where this started, it was reported that finally, after 6 weeks of essentially being under house containment, all the citizens of Wuhan could come outside and are doing so. Yesterday, as I'm sure many of you know, the big three in Detroit, Chrysler, Ford, and GM, said it would be shutting down operations throughout North America at least until the end of March. Last night and yesterday, the U.S. government continues to move forward on a $500 billion package that will include direct payments to taxpayers. In California, 9 million people have been under what is called a stay-in-place order, that is, to be ordered to stay inside in the San Francisco Bay Area. And last, this morning, New York Governor Cuomo warned that the New York health system was going to be overwhelmed. That's the backdrop in which we give today's presentation. The agenda for today is we're going to start out with Tim Gutwald talking about these executive orders up on your screen. He'll then speak a little bit about telehealth, then talk about some HIPAA guidance and how that impacts us in HR. He'll then speak about CMS waivers. After Tim is done with that, I'll talk about a variety of employment issues. And Tim, I'll kick this over to you.
All right, thank you, David. I'm sure, like many of you all, every morning is unusual at this point. We wake up to find new rules, new waivers, new executive orders, and so that's what happened to all of us on Saturday morning. I really enjoy my coworkers at Miller Johnson. David's a great guy. There's a great group of attorneys here, but I could generally do without phone calls on Saturday morning as I'm making pancakes about new executive orders, limiting who can come in and excluding people from healthcare facilities. But that's what we woke up to on Saturday morning. There was Executive Order 2020-06, which has since then been replaced by Executive Order 2027 or 2020-07. And what that did was it required covered facilities, and I'll address who exactly that is in a minute, to exclude visitors and to conduct mandatory health assessments of individuals entering these facilities. So who did this apply to? It applied to sort of four categories of facilities. It applied to healthcare facilities, residential facilities, congregate care facilities, and juvenile justice facilities. I'm not going to identify all of the impacted providers, but please contact us if you're wondering if this applies to you. Kind of the overarching theme or message that I've been providing to clients is, if you have a state of Michigan license and you're a healthcare provider, then this is going to impact you. It quite clearly applies to hospitals, homes for the aged, nursing home, hospice residences, freestanding outpatient surgical facilities, also called more commonly called ambulatory surgery centers. It applied to adult foster care facilities, psychiatric hospitals, child care institutions, and assisted living facilities as well. So those are the category of providers who are now required to prohibit visitors with certain exceptions and to screen everybody coming into the facility, and that quite clearly does include employees. So as I mentioned, originally 2020-06 executive order applied to was a categorical exclusion to all visitors. 2020-07 provided some clarifications. For example, like parents can come in, guardians, court-appointed guardians, or people that are needed for activities of daily living are also permitted to enter these facilities. Importantly, even assuming they fall into one of those categories or an employee or one of those other categories, there needs to be a mandatory health assessment that's conducted of each of those individuals. So what is a health evaluation? At a minimum, it means asking if the individual has a fever, shortness of breath, sore throat, or has had contact with a confirmed COVID case in the last 14 days. In addition, we've had clients, other people have expanded these questions. They've asked about coughs or body aches. They've asked about international travel or domestic travel, particularly to the, China, Iran, Italy, those kind of locations. People have progressively been adding other countries like France and Spain as well. I think one thing to keep in mind, a couple things to keep in mind. One, how many yeses are you going to permit? If someone has a fever but says no to everything else, are you going to allow them into your facility? Are you going to let them work if they're an employee? If the other question is, remember, as you add more questions, you're more likely to get yeses. And as this progresses, it might become harder and harder to have employees, to get employees to show up to work. David's going to address some of those issues in his portion. And so you want to be careful as you ask more questions and have more strict screening. Are you going to rule out too many people? You obviously need to keep people safe, but we do want to emphasize that in order, you don't have to ask all of those questions to comply with the executive order. You need to cover the fever, shortness of breath, and sore throat, and ask about confirmed contact in the last 14 days. This has usually been accomplished as people walk in the door often with a form that they're filling out and signing. Some of our clients are using scanners to take people's temperatures as well. And as I mentioned, it clearly applies to employees. With respect to 2013 executive order, what that does is basically expedite a lot of the licensure approval difficulties for hospitals in particular. Emergency certificates of need generally certificate of needs are required to add beds or do any number of things for hospitals and other healthcare providers, add surgical rooms, that sort of thing. And you can now, they're expediting emergency requests for that. There's additional waivers for, building temporary facilities for hospitals as well. And in addition, they made licensing for CNAs they expedited that process and made it simpler. They're foregoing continuing medical education requirements and renewing licenses despite people not meeting that. And in general, as you'll see a pretty consistent theme as we go through these, you'll see that they're really trying to get administrative and regulatory obstacles out of the way as best they can, or at the very least kind of expedite that process. So, having covered that, we can move to telehealth, which is the next slide, and kind of the most common questions that I've been getting over the last few days. As people continue to as this virus continues to spread, we see that there's a need to avoid having people coming to physician offices, avoiding people coming to the ED. How can we service these people that need to be seen by a physician? And so both private payers and public payers have tried to get out of the way as best they can. Both Medicare and Medicaid have waived certain restrictions. There are differences between those. I'll try and highlight a few, but a lot of the analysis is fairly fact-specific. But when we're talking about telehealth, two important definitions are originating site and distant site. The biggest development here is that both Medicare and Medicaid have broadly defined originating site to permit people to have telehealth visits from their home on their own personal devices. So a patient can be at home, they can call into a physician office, they can use, there's a variety of telehealth technology out there. It needs to be, for Medicare purposes, it needs to be audio and video. For Medicaid, it can just be audio. And then, you can interact with them, you can bill for those services, seeing them. Medicare has some good information in their, publications about the different types of visits you can do virtually. In addition, there's distant site. There's more flexibility, particularly with Medicaid. I think physicians under Medicaid could even be at home and performing these telehealth visits. Medicare, it's less clear that would be allowed. One question I've also received is about controlled substances. The DOJ just recently made it very clear that, in fact, given the emergency situations, providers can prescribe controlled substances, as long as you have a bona fide relationship, as long as you are following federal laws and it's medically appropriate, then you can, without a face-to-face visit, issue a prescription for controlled substances. CMS also provided some additional flexibility to Medicare Advantage plans as well that permits them to expand telehealth and make payments for more types of telehealth service And previously, especially under Medicare, this was really just limited to rural areas, and that has been taken away. So the two biggest takeaways, it doesn't just apply to rural areas, and patients can now be seen while they're sitting at home, and Medicare and Medicaid and other payers are going to pay for that. A couple other considerations to keep in mind with respect to expanding your telehealth services is informed consent. You're going, depending on how you're doing it, there might just be an oral informed consent. If you're using technology, there might be buttons that they can press to acknowledge that they've received informed consent. I would suggest looking at your, informed consent and maybe adding provisions to discuss about the possibility of interruptions, to warn patients that this might not be as private as, an in-person visit. That sort of language I suggest looking at and adding to your informed consent. The other important aspect that Medicare, actually it was HHS, provided was that they made it clear that with respect to telehealth, good faith efforts at complying with HIPAA are going to be, sort of respected. And that means you have broad discretion to use what they call this non-public facing technology. So things like Google Hangouts can be used to provide telehealth services. Skype, regular Skype can be used as well, or FaceTime Messenger video. So this will hopefully provide much more access to providers. The last thing I'm going to say on this is that there are limitations on the type of providers that can do it, but it does include physicians, it includes psychologists, it includes social workers and dietitians. So it's not everybody can provide these services via telehealth, but a broad section of providers can. So David, we'll move to the next slide. And that kind of leads nicely into our HIPAA patient confidentiality provisions. I think the broad takeaway here is that the message from HHS is that they're going to exercise discretion on their enforcement mechanisms. They're really going to focus on the good faith efforts to comply with HIPAA requirements. There's always been flexibility built within HIPAA with respect to, for example, sending encrypted email. I think the message here from HHS has just been that there's going to be less scrutiny, and you need to take measures to try and keep these things private. So when you're doing a telehealth and you want the physician to be in a private place where, other people can't just come in, certainly where there's no other patients around, and you want to encourage your patients to do this from, a bedroom or someplace private within their own house, or, for nursing homes looking to offer this for their patients, find a room where they can do this in private, and so that you're doing your best to comply with HIPAA. Those sort of steps will provide you protection. There's, again, CMS and HHS are really doing a good job at providing guidance on these things. I encourage everybody to go look on their websites, and we'll try and make some of that available through our alerts that we send out at 4 o'clock every day, provide some helpful links. But with respect to treatment, for example, they made it clear, the Office of Civil Rights did, that you're allowed to, for example, tell another patient, disclose PHI to another patient if it's relevant to them. When we're dealing with infectious diseases that they've been exposed to someone else, another patient who had it, that sort of information is clearly pertinent to the treatment of patients, and so that's going to be permitted even without a patient authorization. There's broad discretion to provide information to public health activities. There's an obligation to disclose a positive test to, your local public health agency, and you're just going to be, especially for public health activities, quite clearly now, you're not going to need authorization, and you're going to have a fair amount of discretion with respect to that. Disclosure to family, friends, and others. Again, there's additional guidance there that's permitted. Providers are likely to find more situations where someone does not have end of life or clearly expressed wishes, and so they'll be able to work with families, friends, and others to identify a patient's wishes as a result of that. Again, we're dealing with a public health emergency, so the HIPAA has a permission to disclose PHI for serious and imminent threat as well. So if someone is walking around with coronavirus and they're ignoring things, that's a situation where you might want to consider disclosing PHI for serious and imminent threat. But we do have to be careful with respect to disclosures to media as well, and recall that HIPAA does have some significant restrictions when it comes to that. With all these things, you want to do your best, again, to disclose the minimum amount of information necessary, if at all possible. All right, David, if you want to move to the next slide. All right, I'm not going to get into too much detail, but the government, when President Trump declared a state of emergency and when HHS declared a public health emergency, that triggered some waivers they're called 1135 waivers. And so there's a helpful guidance and letter and fact sheet that CMS has issued regarding the different waivers that they've issued. I'm highlighting some of those here. Waiving 3-day prior hospitalization requirement for skilled nursing coverage. That'll be helpful to hospitals as they become busier and need to free up beds. They'll be able to send patients to a skilled nursing facility if that's a good avenue for them. Hospitals are going to be able to house inpatients at inpatient rehab places or facilities or rooms in their hospital. They're going to be able to house them in other places as well. There's just additional flexibility about where inpatients can be put within the hospital itself. Again, there's a lot of waivers with respect to face-to-face encounters. A lot more can be provided via telehealth, including replacing durable medical equipment for patients. Medicaid just issued some additional guidance last night through a bulletin, a proposed new policy that relaxes those face-to-face requirements and really encourages providers to use telehealth as an alternative to having patients come in. Again, providers, everybody's going to be figuring this out as to when it is appropriate to see someone virtually versus the need to see it in person. And, people are going to have to use discretion and figure out, what's working for them and what's working for patients as well. So obviously, there's a lot more that we could get into. There's more coming out every day that impacts providers. And we'll do our best here at Miller Johnson to include, client alerts and to have information going out on a nightly basis as these new regulations and proposed policies come out. So with that, I'm all done. I'll turn it over to David.
Thank you, Tim. And if I was more technologically savvy, I'd hit a button and everyone would hear some applause to thank you. But unfortunately, I don't have those skills. We're going to move on to the employment issues now. And in the employment issues, before I get going, we received this question beforehand, and it dovetails into some of the topics about which Tim just spoke. And that has to do with questions I can ask employees about their health condition that may relate to COVID-19, and what information can I share if I find out that an employee has or is suspected to have COVID-19. Well, so part of this is easy to answer, and part of it is a little more complicated. As it relates to what you can ask your employees about their health condition, and Tim talked about the governor's order that's requiring all of you to ask your employees and other visitors and other providers every day health evaluation questions. The EEOC came out yesterday with a guidance that made explicit that indeed it was not a violation of the ADA for our employers, including the healthcare organizations, to ask employees specific healthcare related questions related to COVID-19. So you can ask someone all the guidance that you see from the state of Michigan, the guidance from the federal government, the guidance, frankly, from your internal folks and experts that say these are the types of questions we need to ask our employees to make sure we're safe. You don't need to call your employment lawyer anymore and ask if you can ask those questions. Go ahead and ask them. The second thing, though, is what do you do with that information? Is that now information because we can ask the information? can we now then share the information more broadly? Under the ADA, the answer is no. The EEOC stated in its guidance yesterday that employers must, not can or should or whatever, must maintain all information about employees' illnesses as confidential medical records as required by the ADA. And as you know, under the ADA, all of our medical exams and medical information can only be disclosed to those people on a need-to-know basis. And in that circumstance, generally it means it has to do something directly with that employee and is not something you would broadcast. I think it leaves unanswered the obvious question that people have is, can I disclose to coworkers that if it's David Buday that has it, that David Buday has tested positive for COVID-19? Again, I think we're going to defer to the health department. We're going to defer to the regulatory agencies that give us guidance. If they tell us we need to do so in order to do an investigation to help public health, we're going to do so. In the cases that we've seen, the Community of Public Health has got involved and has notified coworkers, and obviously that spreads. Obviously, we don't need to put a billboard up in our hospital that identifies by face and name all of our employees that may have tested positive for COVID-19. That's insensitive, it's unkind, it's unnecessary. But of course, there are circumstances where we're going to have to disclose potentially people's names in order to determine how far out the circle has gone and to make sure it's safe. And again, in the healthcare environment, you guys have additional sensitivities because you have patients on other floors in other parts of your hospitals that have not tested positive. So you may need, and again, I think looking at public health, to not be so overly concerned about the ADA, but to do what is right for the community. Again, what I don't think people should hear is that we should not be sensitive to these issues. But I think, again, Tim said this, he's right. This is a public health emergency, and we should behave accordingly. So I think that is one of the questions that people repeatedly have here, and something I want to touch on at the outset. Next, another question that we have, we've read stories about this. This is not widespread in the states that are in front of us as far as this goes, California, the state of Washington, New York, but there are reports of this occurring, and that is, what do we do when someone who's on the front line, a nurse, an aide, a doc, says, you know what, I'm out. I'm scared. This is crazy. There's too many patients coming through the door here. I have a family. I have a life. The risk is too high. I refuse to take care of this patient, which, folks, is going to happen. Well, I think the first thing any employer is going to do is they're going to speak to that individual directly about their concerns. And obviously, I hope that we have kind of a chain of command, so to speak, that you go through. The nursing manager, the director, the frontline person will try to communicate with the individual to try to take care of their concerns. We're going to hear concerns about not having the necessary safety equipment. We're going to hear concerns about not having the necessary people around to help. We're just going to hear concerns, and we need to listen to what those concerns are, and then we need to see if we can address them. And of course, addressing them on the floor in front of the patients is not wise or not helpful. So we need to think about this ahead of time for our managers and our leaders. How are they going to do this, and where are we going to take this individual to speak with them? Beyond that, are there educational tools that we're going to have available to maybe educate someone? Maybe in this case it's an EVS worker that doesn't have the knowledge of a physician or a nurse, that may be misinformed. It may be some other type of worker. How are we going to communicate and educate someone who may become afraid, but their fears are not based in fact, but based in some type of hysteria or misunderstanding of information? So the first thing to me has to be, how do we try to get the people back out doing the job through information, discussion, relieving fears, concerns, getting them to feel safe. So I think as HR, our role is to script all of this out to some degree, so we're thinking through these things. The next thing that you have to understand too is what type of contractual relationship you may have with the employee at issue. In a healthcare facilities, the types of contracts that we have is we obviously have our collective bargaining agreements in the unionized setting. We obviously have contractual relationships with providers, and those are specific individual contracts. So if by contract we have some provision that allows those individuals to not perform work, that also becomes an issue. Another area, and it becomes an issue, since just understanding it. And the other issue is, can we fire these people? Or can we fire these people? And that gets into an area that you've heard a lot about as HR professionals, and that is protected concerted activity. Well, protected and concerted activity includes the right to go on strike with my coworkers to try to change work conditions and or to try to compel my employer to do something on behalf of all my coworkers, to get more protective equipment, to get more employees in here, something along those lines. So we have to be cognizant of that fact. Why are employees doing this? Are they doing this to go on strike? And if they do so, then arguably they could be protected and they could get their job back if we discharge them. But that brings me to this third bullet point in my slide, and that is we have to align with senior leadership on how to handle these cases today. And what do I mean by that? Well, let's take a nurse. A nurse is on the front line. She's been working. She's on her 7th 12-hour shift in a row where we've seen an influx of patients. She's under tremendous amount of stress, and she's refusing to work. In that circumstance, are we going to send her home with pay and benefits? Are we going to send her home without pay and benefits? Are we going to reassign her within the hospital? Are we going to discharge her for refusing to work? Those are all options, and they all have merit. None of them are wrong, even the discharge option. Even though I mentioned the protected concerted activity, I think that I would not get wrapped up in that, because what I would focus on is what is the right thing for your organization and what message do you want in the community. I think this is also an area for our public relations folks. If we discharge nurses, care assistants, or physicians for refusing to work and doing their job, or we lay them off or suspend them, so to speak, without pay and benefits, some type of media may pick this up. Social media, conventional media, and you're going to be asked, you being healthcare organizations, are going to be asked why. So to me, this whole area is something we are likely to see as this moves forward, and workers get tired, they become scared, those types of things. So from our standpoint, it's an issue that you should be out in front of and be proactive about. The next issue that has come up for us is on-site child care. We've worked with a healthcare system that has worked through this process, and last night, Tim mentioned this, every morning that I wake up, there is another executive order from our governor. There's something the federal government has done. Last night at 9:30 p.m., the governor issued an executive order as it related to on-site health care. Before I talk about that, I just want to talk to you about our experiences with this issue, because it may be helpful to other healthcare systems. As we know, as a healthcare system, one of the things that we in HR are charged with is making sure there's enough individuals, nurses, care assistants, EVS workers, food workers, etc., enough of those folks to take care of the influx of patients that we believe are coming, whether it's in 4 weeks, 6 weeks, or 8 weeks. And so we're doing our darndest to make sure that's going to occur. However, it is not particularly helpful when we have our school systems that are shut down, and so all of our workers who have children that are school age that used to be taken care of from the hours of 7 to 3 or 7 to 5, depending on the school district, are now in need of child care. And so the idea is, what can we do to make sure our employees can get accessible child care, affordable child care? And so we've seen healthcare systems, and we've worked with the healthcare system, who has opened 2 healthcare facilities at one location, which is a satellite location where they had a wellness facility, and one near their main facility where they also had a wellness facility. We worked with the state of Michigan and Lara worked on an expedited basis and a reasonable basis to assist that healthcare institution with getting the necessary OKs and assurances that that was good to go. In both those locations, they had a history of providing some type of daycare, and so they had the facility set up. They had individuals who they'd already employed who could work there. Those 2 locations, though, did not come close to meeting the need that the institution projected that they would have in the future, and so they looked to community partners to work with, and they happened to be able to partner with the YMCA, and the YMCA, as you know, they're all closed down as it relates to our ability to go to the gym and exercise and all those things, but the buildings are still there. The people, although laid off, are still in our communities, and the YMCA was happy to help. And again, many of our YMCAs in the state are set up to be able to provide that type of assistance, and so there was a partnership. And again, we're able to work with them on an expedited basis to get the necessary assurances that they already had licensures, they had the safety protocols in place, they had the right facilities, they had the right insurance, and we could work through those things on an expedited basis and be able to get that up and running. So we were able to do that. In that particular circumstance, I can tell you the HR folks worked a tremendous amount of hours to make that happen. Now fast forward to last night. Last night the governor again issues this executive order, and what it does essentially is this executive order tells the state of Michigan that for hospital workers, for first responders, for the people that are providing essential services that we know are going to be burdened to work lots of hours and who have children, we need to provide child care. And so the state's idea is to have the communities use their intermediate school districts, their ISDs, to coordinate these efforts to use our schools' facilities and resources to provide the venue for that, and to work with whether it's for-profit organizations or non-for-profit organizations or other community organizations like churches, whatever, to provide the necessary people to provide that child care, that they're opening those avenues of communication and trying to coordinate. It goes back to the initial comments I made. We as a state need to be good neighbors, and I think that's what the governor is trying to facilitate in these efforts, utilizing the organizational structure of the ISD. If you go up on the state's website and look at this, you will see that they include a link for our employees, for your employees who need child care assistance, to be able to click on there. I did it this morning. You click on there and it asks you your name, where you live, how many children you have, who your employer is, and then you submit it, and the idea is the state or the ISD will then contact the individual with the resources that are available or will be available in the communities. So the child care piece, I think, is moving forward aggressively in the state. I think this is good. I think it's going to take some of the burden off you folks' health care, and hopefully the ISDs in our various locations will start to work with you and coordinate these locations and set things up so you folks in HR are not burdened with this. But that is something that is obviously moving quickly. This was an example of Larry Horvath, I don't want to say his name, I'm sorry, the director of Laura had sent this out this weekend to a medical center, indicating that they would be moving quickly to allow healthcare organizations to set up on-site daycare centers. And our experience with Laura, as they have been flexible and reasonable, and they have worked very expeditiously, at least experience, and I would expect that to continue based upon the governor's order. Next, on-site childcare. Oh, this is important. They're relaxing the regulatory requirements for you folks to open up child care facilities. And if you do that, even though they're relaxing it, you should still become familiar with all of them, and you should still work to making sure you dot all those I's and cross all those T's over time. These are our employees' children's, and to the extent we haven't done all that is required by the regulations or don't do it as we evolve and something bad happens, we will be held accountable. So even though they let you quickly get licensed, I do think it's important to have professionals involved that are familiar with these areas, and that these individual, and then you as a healthcare organization work to take care of it. We talked about other options for things for people. Again, this was before the governor, and she picked up on this, and I think this is absolutely appropriate. I think the healthcare organizations need to lean on their communities. I think there are many of us out there that are willing to help, and we recognize that we're going to be asking a lot of our healthcare workers, and if we can help by making sure there's safe places and affordable places for the children to be cared for, I think our communities will do what they need to do and help out. Next question: Can the healthcare system restrict travel for employees who provide direct patient care? Tim talked about how you folks are doing healthcare evaluations, and we have a number of healthcare systems that one of the questions they're asking individuals before they come to work or come in our facilities to provide care is, have you traveled in the last 14 days, 30 days? If so, where? And as we know, there are certain travel restrictions that the CDC has put out to countries such as Italy and China and South Korea, Iran, etc., and that if someone has traveled there, then of course the answer is then we're not going to let them work. We've had clients take it beyond that to say if there's any travel to Europe and other countries to, again, not to allow them to work. And so we're asking these travel questions to our employees. It is entirely lawful and appropriate to do so. Likewise, it is also appropriate for you to restrict travel. That is, as a healthcare organization, you can tell your healthcare providers that during this public health emergency, we want you to restrict your travel because you need to be safe to be able to do your job. And if you're flying on airplanes, traveling to New York, California, state of Washington, etc., you're enhancing your risk in a way that we believe is unacceptable and may make you unable to do your job safely. So it is appropriate for us to do that. Okay, whether you want to do that for everyone is healthcare by healthcare organization's decision, but it is absolutely lawful for you to ask that. The one thing is HR people we have to be careful of. When I say that, we don't need employers then to say, well, if I can restrict their travel, I can then restrict what they do when they are at home or in our community. That, then you start to get into Fair Labor Standard Act issues, and the distinction the Department of Labor means if someone is waiting to be engaged, they are not paid. So if we require someone to be in the community and someone that needs to stay here in general and they have to be available for their next shift, there is no compensation issues. On the other hand, if we require someone to stay within a mile of the facility, to be able to be in the facility within 5 minutes, to restrict when they sleep, to restrict what they drink, to restrict anything in their movements in significant ways, then that starts to look more and more like wait time, and therefore that engaged to be waiting time is compensable. I don't think this will become an issue immediately, but as we move forward, we're in HR, and maybe we're going to need to house people in our healthcare facilities, that is our providers and others. And if we're requiring them to be 24/7 on a call, even though they're in a room sleeping, but they have to jump up immediately and get there, we're going to need to analyze whether those are compensable times if we're going to do that to folks. So an issue to put on your just remember list as we go forward. And again, hopefully our state won't get to that point, but it may. Next is unemployment benefits. Did she extend it to related to the coronavirus? She absolutely did. There was a release on March 16th when she did that, and she did it for these reasons. She said, if you have family care responsibilities due to school closures. So in the state of Michigan, if you say, look, I can't work at the hospital because I have 3 children ages 7, 9, and 11, I no longer have someone to watch them, you have the right to not come to work, apply for unemployment benefits, and receive unemployment benefits. That is unusual and remarkable. And I understand why. And for most industries right now, because things are slowing down in most parts of the economy, that isn't particularly problematic. In the healthcare organization, where we have staffing challenges and shortages, this does provide a modest economic incentive for people to do that. As we know, I think the maximum unemployment benefit is $360, and obviously for lower wage workers it's lower, so it isn't as if someone's going to get rich not working, but at least does provide some type of benefit. If you have a family member who becomes ill as well, you can seek unemployment benefits in the state of Michigan. If the individual has symptoms or is under self-quarantine or self-isolation and they do not have paid sick leave, and it's the do not have paid sick leave, most healthcare organizations provide some form of paid sick leave for at least some amount of time, and so it's unlikely the individual will get unemployment in that case. And of course, if they call us first responders, and you're quarantined. So if you're quarantined and you can't work, then you're unemployed and you get that. So the state is trying to fill in the gap for organizations that may not provide a health care benefit. This is the actual order itself. We don't need to walk through that. I already went through that. Move forward here to the Families First Coronavirus Response Act. And all you folks on the phone who have 500 or less employees, your world just changed. It is now family medical leave, all the things you know and love about that, with now money. When I typed this last night, the Senate had passed the bill. The President had not signed it, but the President did sign it last night. It is indeed the law of the land. What are the key provisions about this? You get 2 full weeks of full pay for covered absences. And again, I'm going to say this, 500 and less employees, all right? Not large healthcare organizations like Spectrum, Bronson, or Sparrow, or Beaumont, or U of M, those systems, Mid-Michigan, those are way beyond that. This does not apply to you. It applies to the smaller healthcare organizations that are left that are on the phone. And so you have 500 or less employees. If you have a covered employee, which means someone who has worked for you for at least 30 days, if that individual has to take an absence from work in anything, and I'm saying this in as broad a sense to get this, anything related to the coronavirus, that is, I have it, I'm quarantined because of it, a family member has it, or I need to care for the family member for some reason because of that, or because I have school-age children and school has been shut down. And it's the last one that obviously is going to catch a lot of people. In that circumstance, that individual employee is entitled to 2 weeks of full pay for the covered absence. In addition to that, the remainder of the leave period is not exactly accurate. Happens then, the way it's written, is they're entitled to 12 weeks of pay, of which the 10 weeks that follow are 66% of the pay. So there's 2 weeks of pay, and then there's 66% of pay for the individuals who get that as well. They also get, when I say FMLA type protection, that means they get health care, that means they have job protection, that means we can't discriminate against them because of the leave. So if someone fits into this leave, it's as if they're on an FMLA type leave. And again, a continuation of health care. So this law is a significant change, and employers are going to be reimbursed through tax credits, so that the federal government is going to at least advertise that it is paying 100% of this. I'm not a tax lawyer. I don't know exactly what percentage they will pay and how that really works out, but the reality is that's what it is. I just received a question that said, does the FFCA include employees who are sent home due to a lack of work? On our initial reading to that, the answer is no, it does not. If someone is laid off, they do not fit in one of the covered categories that I just said. That is, they weren't on layoff. They weren't off work because they themselves are sick, or a family member is sick, or because they're taking care of a child. They're at work, and we simply shut down operations or cut back operations and lay them off. Then the individual would not. The individual would not be entitled to this FFCRA money. All right. Miller Johnson is on top of this. We've already put out, I think, client update last night on this. Next week we will have webinars on this. You will see that coming. I don't know if it's going to be on Monday or Tuesday or Wednesday. We got to get our heads around here, trying to see how this law coordinates with FMLA, and it was written in haste, so we've already seen lots of inconsistencies. We'd like to find some answers so that when we're giving the presentation, we're not saying this is uncertain or that's uncertain. Instead, we can give you what I consider a more direct answer. Let me see here. All right, there's my face. That seems kind of unnecessary, but anyway, it's there. The next, I got a question here. It says, what if an employee is coughing, has a sore throat, and stays home until symptoms subsides but is never tested? It says, because we've asked the employee with these symptoms to stay home. Yes, I believe under the FFCRA, the way it is written, it is likely, more likely than not, that will be covered, and if you're a covered employer, you're going to have that problem. Ask if this applies to part-time employees. My understanding is yes, but I think there's, again, a part-time employee's wage for those 2 weeks is less than a full-time employee. The law is going to go in effect, I think it's 14 days. Someone asked it's 15 days. But again, I don't want to spend too much time talking about this. We'll put out webinars, and frankly, I've read through it once and say that I fully understand it and cut out every nuance. I'm not that smart, for those of you on the phone who know me. But we will be all over it, and you guys will get detailed guidance. We have time. We have 14 days to digest all of this and move forward on this. So with that, I think I'm going to sign off this webinar, and again, I'm going to sign off by thanking you and all of the people that do the amazing work that are going to help keep our communities safe and get us through this. So Take care, and Godspeed to y'all.